I'm Dr. Rajeev Chawla, Senior Consultant Diabetologist and Director, North Delhi Diabetes Center, Rohini, New Delhi. It's nice to interact with you through this platform. We all know diabetes is an independent risk factor for cardiovascular disease. All CVD for that matter, or coronary artery disease, stroke, PVD, or macrocytic complication, risk rises in the setting of type 2 diabetes, and it is almost graded as 2 to 4 times as compared to non-diabetic population. That is why it has been said that diabetics are CV risk equivalent. So all the guidelines today are absolutely aligned and absolutely unanimous that if you have multiple CV risk factors or established atherosclerotic cardiovascular disease, patient ideally should be on either GLP-1 receptor agonist or SGLT2 inhibitor, because with both we know there is going to be a 3-point MACE reduction, there is going to be a significant reduction in hospitalization and heart failure, as well as renal composite endpoints are also going to come down. In spite of being on SGLT2 inhibitor or GLP-1 receptor agonist, patient is still not able to get an HbA1c close to 6.8 or at least less than 7, then it makes huge sense adding DPP4 inhibitor, that too particularly DPP4 like sitagliptin, because it is CV neutral. We are wiser from ECO study that CV risk with sitagliptin is hazard ratio is only 1, so there is no added risk of heart failure or any other CV endpoints with sitagliptin. So that is how someone who is not getting a good control on SGLT2 inhibitors or GLP-1 receptor agonist, or neither they can afford or they are not tolerating one of these drugs, they will be the best candidate for sitagliptin therapy. Sitagliptin will be best option, especially in those patients, those who are at a little greater risk for having hypoglycemia, say elderly patients. So their sitagliptin comes out to be very, very safe, because it will neither increase the risk of hypoglycemia nor it will increase any cardiovascular risk, as I already said, based on ECO's data. So it becomes a wonderful option after metformin, maybe either before SGLT2 inhibitor or GLP-1 receptor agonist, or after these drugs, so as to get a good glycemic control. Those who are already on metformin and maybe they are already on SGLT2 inhibitor or sulfonylurea, but these days we understand that if the HbA1c, what that patient has in that particular setting, is more than higher or higher than 1.5% as compared to the target values, like most of our patients, we will target an HbA1c close to 6.8 or 7, but if you see the baseline HbA1c in that patient is already close to 8.3 or 8.5, it makes huge sense of starting or adding a combination therapy. Then we should not go by a stepwise approach that we wait for 3 months and then add on another drug. Best in that setting will be that right in the beginning we may start it as a combination of maybe metformin with DPP4 for getting a good glycemic control, or maybe after metformin we can also combine a DPP4 like sitagliptin along with an SGLT2 inhibitor, which could be dapagliflozin after metformin, to get not only a euglycemia without a added risk of hypoglycemia, and we know both the drugs are going to work in a synergistic way. Whenever we combine two drugs like SGLT2 inhibitor and DPP4, not only we have synergy in